Hello, everyone. Good morning, good evening, and good night to all dear friends, colleagues from all around the world. Welcome to the last session of the last day of 33rd International Congress on Pediatrics. We are here with you from Tehran University of Medical Sciences, Children's Medical Centers Hospital. I'm Dr. Mahia Qahramanlu, pediatric resident at Tehran University of Medical Sciences, Children's Medical Centers Hospital. So glad to be here and so proud to be here with you and be a part of the amazing executive team of the Congress. Now we are going to have a special session on managing an ill child by dear Professor Srinivasan, dear Professor Mani, and dear Azadeh Assadi. If you are ready, we are going to start the session. Hello again and welcome, dear friends. Please pay attention to these little points that I mentioned. Please make sure that your microphone is muted and your video is off during the lectures. Please do not forget to register on our web application in order to receive your certificate of attendance. You will receive it within 7 days in English, and please log in here with your full name in English. Because the list of Zoom audiences will be matched with the list of registered applications on our web application in order to receive your certificate of attendance. And all their Iranian attendees will be able to receive their CME credit via ircme.ir, and do not forget to take the exam at the end of this session. We are going to start our particular session on managing the ill child by dear Professor Alireza.
Oh, thank you very much. Thank you, Dr. Qahramanlu, for inviting me to give this talk. Hello, thank you very much.
Thank you so much. Dear Professor Alireza is an associate professor at UCLE, University College in London. He enjoys working on interdisciplinary projects both as a researcher and teacher. His main area of interest is understanding the complexity of physiological control in critical illness, and he has had success in combining mathematical modeling and clinical medicine in his research. Alireza studied medicine at Tehran University of Medical Sciences. Dear Professor Mani, welcome to our Congress, and so many thanks for accepting our invitation. Such a great honor for our Congress to have you here, and welcome again.
Thank you, Dr. Qahramani. That's very, very kind. Thank you for invitation and also very kind introduction. Let me share with you my screen and my slides.
Yeah,
I will start my presentation, which is on network physiology approach to hypoxia. I would like to share what we do in our lab, in the network physiology lab at UCL, and we hope that that kind of research might be helpful and might have some application in future in the intensive care units. So let me start with appreciating the complexity of oxygen, of tissue oxygenation and its regulation. So when we look at all of our physiology textbooks, we know that actually the regulation of tissue oxygenation is very important, and it is also very complex. Usually in the intensive care units and also in assessment of patients, we want to assess the integrity and engagement of this sophisticated control system. And for instance, imagine if we want to assess a patient for extubation and so on and so forth. The question is, what is the best approach for assessment and measurement of the integrity of these very, very interesting physiological systems. If we try to think about different ways, different approaches for understanding this control mechanism, we have two classical approaches. The first one is the common classical reductionistic approach that we have used in the past, I guess, 100 years. Many physiologists, many pharmacologists, including me, try to understand the complexity of physiological control using a reductionistic approach, which means by breaking down different components of the system, right? Imagine, for instance, we can isolate some cells that are involved in chemoreception for oxygen to sense how much oxygen we have got in our arterial system. We can dissect the brain stem to put electrodes and understand how the electrophysiology of oxygen sensing. We can, for instance, look at several neurotransmitters involved, try to make medications and drugs that interact and interfere with this type of signaling. There are so many reductionistic ways to look at those things, and they have been very helpful. But the problem is, if we want to understand the connectivity and engagement of control system, probably this kind of approach has a lot of shortfalls. It is probably much better to use an integrative approach. But the problem with integrative approach is that we don't have very good tools to look at the whole system. And of course, recently, there are a lot of advances in combination of informatics, information theory, and so on and so forth to shed light on understanding the engagement of control system, and network physiology, which is an emerging field, it tries to help as well. I want to share with you a few slides and a few research that has been going on in our lab on monitoring hypoxia. I guess in the audience, you are all well aware of the value of using pulse oximeters for assessment and monitoring hypoxia. One thing which is interesting and hasn't been appreciated that much in medical literature is that if you monitor a patient or an individual for the level of oxygen saturation or SpO2, we see that these signals are really complex and they fluctuate a lot. So is there any information there? Can I use these fluctuations for understanding the integrity of our cardiorespiratory system or not? This has been a question that we have tried to address, and we were very surprised when we look at the literature, and there hasn't been a lot of studies on looking at the pattern of changes of SpO2 fluctuations. So if you want to answer such question, for instance, can we use simple non-invasive pulse oximeters and the signals that we record from these type of assessment to get something a bit deeper than just the value of oxygen saturation? We need to answer a few questions. The first question is there any information in these fluctuations, or are we just recording some noise? Are these fluctuations related to just random noise in our system, or is there any information that can be measured and extracted from these type of physiological time series? If there is any information, how to quantify information? What is the unit for information? We know a lot about units for measurement of, I don't know, different materials, mass, body surface area. But if I want to assess how much information is embedded or is processed in our physiological system, what is the unit and how can I measure it? And the third question is, if we can measure amount of information, how can I interpret it? And is it going to be helpful for clinicians and nurses who are actually dealing with and managing patients who are critically ill? So I tried to provide some really simple but interesting answer to this question first, and then I will like to talk a little bit about potential application of such interesting approach. And before I show you some of the results of our lab in the past few years, I want to tell you that answering and addressing such questions require really interdisciplinary collaboration between scientists. So we need a lot of input from clinicians and people who work in intensive care units or hospitals. We need to make sure that we involve physiologists because they know the mechanism very well and they can develop methods that help us to assess our patients. Of course, biomedical engineering and all this discipline is really important, and also physical mathematics. So we need really the interface between these disciplines probably would be very helpful for uncovering many questions that we might have and to assess a critically ill patient. And so to answer the question about how we can measure amount of information or information content in a time series, imagine if we are looking at these fluctuations. I want to know if there is any information or not there. I want to refer to you to the very interesting historical discoveries and inventions by Claude Shannon. Shannon is the father of information theory, and in 1948, he published a very interesting paper which has changed and revolutionized the way we look at nature and also the way technology works. So this area of information theory was birthed because he wanted to measure the capacity of telecommunication channels. He wanted to know if he's going to send a telegram or if you want to call from one city to other city, how much information can pass through one channel and how he can measure it. So he had the same problem. He didn't know how to measure information. What he realized, which actually revolutionized the way we think about information, is that he realized that actually, if you want to measure amount of information in a signal, the signal can be anything. It can be telecommunication or it can be a physiological signal. The average amount of surprise that you see in the message is related to amount of information. So if you want to measure information, you just need to know how much surprise you have got in that signal. This is interesting. This schematic diagram probably help you to appreciate the beauty of this stuff. So imagine if this grandma is talking to her grandchild. The first one is just calling, and the little kid tells da 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 da. Of course, we have some information, but the information is limited, so we don't have that much surprise. The first da da, and then the rest is repetition. So we know that something is happening, but we don't have much information. If you compare with the second grandchild, who is bigger and is talking, he tells, "Hi, grandma, I'm playing Superman." So you see in this sentence, the signal has much more surprise, because if I stop here, "Hi, grandma, what is next? I'm playing what? I'm playing Superman." So this message has much more information. The way to measure amount of surprise was unknown until 1950s, and Shannon's idea was to take the idea and adopt the idea from thermodynamics and from other discipline in physics, and he tried to use the concept of entropy to measure information. So the idea is that we can measure degree of irregularities by measuring entropy. If entropy of a signal is high, it means that the signal is irregular. It means that the signal has high amount of amount of information and high amount of surprise. So if I want to measure entropy, if I measure entropy of a signal or degree of irregularity, probably it tells me something about amount of information. I can measure information content of a signal by looking at the entropy. With this introduction, I want to show you now some results related to oxygen saturation variability and how it might be helpful in future in assessment of critically ill patients. In this case, one of my students in about 5 years ago, he joined our lab and he tried to ask the same question. He tried to see if we record SpO2 variations in healthy individuals with different age, all healthy people. Is there any information there or not? First of all, he used a kind of mathematical methods to see if these signals are random or not. He discovered that these signals are not random. So, and also it is possible to measure entropy of this signal. So there is a way to measure how much information is embedded or stored in these SpO2 variations, which is interesting. So it is very easy. Using a very simple algorithm that can be added to any mobile phone, we can measure entropy of SpO2 or oxygen saturated oxygen saturation variability signal. So it is very interesting. Now, if you compare people who are young and people who are older, imagine people who are younger than 35 and people who are a bit older than 35. We are talking about healthy individuals. If you compare the entropy of the SpO2 signal at different resolutions, for instance, I can just record SpO2 every second, or I can record it every 5 seconds. So at different resolutions of measurement, what you see in the x-axis is the resolution of recording, and here in the y-axis you can see the entropy of SpO2 signal. So you see that in younger people, the entropy is higher than older individuals, and we are talking about healthy individuals, which is interesting. So in aging, it seems that the amount of information that is processed or stored in the SpO2 signal is reduced. This is interesting. It makes sense because in aging, we have a little bit of disruption of many physiological regulatory systems. This is interesting. We try to see if this is as an accidental finding, or we can actually challenge the physiological system and observe similar phenomenon or not. We have very good collaborators at the University of Portsmouth. They work in the on extreme environment, which is a very interesting idea. So in their lab, they have hypoxic chambers. So they have volunteers. The participants go inside a hypoxic chambers to experience different degrees of hypoxia. In this case, if we change the FiO2 or the percentage of oxygen in breathing air from 21%, which is normal, up to so down to 17, 14.5, and 12%. So if you see the raw signals here, the raw signal for SpO2 is a bit irregular in healthy individuals at FiO2 of 21%. By increasing by the degree of hypoxia, you see that, first of all, of course, mean SpO2 is reduced as we expect, but the degree of irregularity is increased as well. This is very well reflected when we measure SpO2 entropy. So when you look at the entropy or amount of information that is processed there, you see that there is an significant increase in entropy of the signal. This is very interesting. So we thought in healthy individuals, entropy of SpO2 changes with the challenge, with the hypoxic challenge. And something which was surprising for us was if you measure the degree of breathlessness. So breathlessness is a subjective feeling, and it is very difficult to find an objective measure to measure breathlessness in someone. If you put healthy individuals in hypoxic chamber and ask them to fill a questionnaire and rate their breathlessness, it is very interesting. Mean SpO2, the raw value of SpO2, the absolute value that we measure in our monitors, it doesn't correlate with the degree of breathlessness, but entropy of the signal, if you look at the entropy of the SpO2 signal, is correlated significantly with breathlessness, which is interesting. So for the SpO2 entropy of a healthy individual at FiO2 of 17%, a little bit hypoxia correlates very well with the degree of breathlessness. And it can also predict how the individual feels at lower FiO2s as well. So this is interesting. It seems that SpO2 entropy, which talks about the measured amount of information we have in the signal, is predicting or is correlated with the subjective feeling of breathlessness. This is interesting. Based on these experiments, these are all very preliminary experiments, but we thought that we might hypothesize that if I want to measure the engagement of respiratory control, we might be able to use SpO2 entropy because it is a signal that can be measured very easily, non-invasively everywhere. Everywhere it's very easy, and it is convenient for all healthcare workers to have a pulse oximeter. You just need to measure entropy. You need to add software to calculate the entropy. So the idea is if SpO2 entropy indicates engagement of control system, so it can be a helpful tool for us as well. It looks like that if you want to, for instance, if you are just compare it with the political system, if there is no challenge in a country, of course, you don't expect the member of parliaments to discuss a lot in the parliament. Usually when there is not much interesting discussion or there is no challenge for a country, not all members of parliament attend the parliament, and there is not much information processing, and there is no challenge. Then when we have a challenge such as hypoxia, then you expect to see an increased number of discussions, increased number of people who attend. So you expect to see an increased entropy of all of those discussions as well. So if in health, this works, for instance, if in health, when we have a challenge such as hypoxia, the amount of information processing should increase in a health control system. Does it happen in disease as well or not? So this is interesting. We want to know if this mechanism happens in health. What about critically ill patients? What about sepsis, for instance? Sepsis is a life-threatening condition related to dysregulation of host response to infection. And of course, in some patients in the intensive care units might have multiple organ failure due to sepsis. And sepsis, unfortunately, is related to a very high percentage of global death, especially in sub-Saharan Africa. So there is a very nice paper by a group of investigators on global burden of disease. And the argument is that around 20% of global death, of course, pre-COVID pandemic, was related to sepsis. So sepsis is a complicated disorder. It is interesting, and it seems that the engagement of organ systems, physiological system, is impaired in sepsis. There are very nice studies to show that it seems that the organs the crosstalk between organs and tissues is not optimal in sepsis. So if that's the case, is there any way to look at the integrity of the cardiorespiratory system by using a simple measure such as SpO2 entropy or not? So we try to address this question. So I show you some of the results that has been recently done by one of my students, and Margaret, who is working on her thesis. She used recording of vital sign and SpO2 signals from many patients from the MIMIC dataset. MIMIC dataset is a very interesting open dataset, which is created by Harvard MIT collaboration, and it is based on curating a lot of data from a lot of intensive care units in Boston. So now, if you measure SpO2 entropy of patients in the intensive care unit who are diagnosed with sepsis, and then you look at those 30 days follow-up time and 30 days mortality. So some patients survive, fortunately, and unfortunately, some patients don't survive. Now, if you compare the survivors with non-survivors and measure SpO2 entropy as shown in axis, the y-axis here, you can see that doesn't matter at what scale we are measuring the SpO2. You can measure every second, every 2 seconds, and so on and so forth. Doesn't matter, independently of the resolution of recording, entropy of those patients in the intensive care unit with sepsis who are survivors, these show higher SpO2 entropy. It means that the engagement of system probably is higher. This is one interpretation. Of course, there might be other interpretation as well. So non-survivors have less entropy. The simplest way to explain it is that probably there is a challenge, but their system is the integrity of the control system and amount of information processed in the system is not as good as the ones that survive because the entropy is lower. This is just an oversimplification for interpretation of this study. Let's look at this data more profoundly. What if we try to see, let's do the survival analysis. Is there any for instance, predictive value for measuring SpO2 entropy in patients with sepsis in the intensive care unit or not? So we used a multivariate Cox regression analysis. As you know, Dr. Cox unfortunately passed away 2 weeks ago, who was, of course, a genius statistician who developed so many interesting methods, including the multivariate regression analysis. And so if you look at the data, so of course, so far, as a very good clinical index, is a good predictor of mortality in the intensive care in patient with sepsis. Age is also a predictor of mortality, but SpO2 entropy is also an independent predictor of mortality. And in this multivariate analysis, it shows that the prediction of mortality from SpO2 entropy is independent from SOFA and ventilation status. It doesn't matter if the patient is ventilated or not, mechanically ventilated or not. SpO2 entropy is an independent predictor of mortality. This is interesting. It means that there is a reason for it. And is it related to the link between SpO2 entropy and information content? We need to investigate it further, but this is interesting. If you try to use SpO2 entropy or just only SpO2 mean for classifying patients and prediction of either survivors or non-survivors, you can use a ROC curve. So ROC curve analysis has been used a lot in statistics. So in the y-axis, you can look at the relationship between specificity of the test and sensitivity of the test. And you see that actually for mean SpO2, you don't see that much, it doesn't have that good value for prediction of mortality. But if you look at the SpO2 entropy, the blue line, it plays a role. And if you combine information from mean and SpO2 entropy together, you see that actually you see a very interesting ROC curve with an area under curve of around 0.75, which is very close to actually the value of SOFA. The SOFA score that has been used is clinically used for assessment of critically ill patient with sepsis. This is interesting. So we know that SpO2 entropy predicts mortality, and the value is equal to SOFA if we compare it with the area under curve of SOFA for prediction of mortality. This slide shows the Kaplan-Meier graph for 30 days follow-up of patients. If you measure SpO2 entropy, those patients with higher SpO2 entropy, they are more likely to survive. That is interesting. These patients, in the dot lines, they show that patients with lower SpO2 entropy, they have less chance of survival when they are in the intensive care. So far, I just want to summarize what I mentioned, and I have a couple of more slides to conclude this talk. First thing is SpO2 time series exhibit complex pattern of fluctuations. The second point is SpO2 entropies increase in hypoxia, and it's correlated with dyspnea and the idea of breathlessness. SpO2 entropy can predict mortality in sepsis independently from SOFA and other prognostic factors. This is interesting. If we think about those, still we want to explain and we try to understand, is there any other reason to believe that SpO2 entropy is a good indicator of engagement of respiratory control or not? If we can show that this engagement of so many variables that is involved in tissue oxygenation can be measured by SpO2 entropy, probably that would be a very helpful non-invasive method for further assessment. In order to answer this question, a group of my students with collaboration with other colleagues, we try to look at the engagement of system by trying to look at not only the SpO2 signal that you can see. What if at the same time that we are recording SpO2 signals, you can record heart rate, minute ventilation, respiratory rate, end-tidal oxygen concentration, and end-tidal CO2 pressure, for instance. You can measure all of those things at the same time. Ideally, if you want to look at the engagement of a control system, what we need to do, we want to know how much, for instance, respiratory rate affects, for instance, SpO2 fluctuation. And also we want to know how much SpO2 fluctuations affect respiratory rate. And so on and so forth. We can actually look at how these network of interactions actually work. Ideally, if we can map the network of interactions between all of these components, that we can easily, some of them, at least some of these components can be measured easily in the intensive care. if I can have a look at the relative contribution of causal relationship between these signals, then I can map a network, and that network can be helpful for assessment of patients and also in the healthy individuals as well. So the idea is we want to have a look at it. The question is, how do I quantitate the link between respiratory rate, for instance, the time series and all of fluctuation we have seen in respiratory rate to SpO2 and so on and so forth. Now, based on collaboration with physicists have a very good idea to in order to calculate the relationship between two signals. There is an interesting concept called transfer entropy. I just want to summarize the idea. The idea is that if I have a signal such as respiratory rate, and I want to know how it affects the SpO2, for instance, we want to answer actually this question: how the past of respiratory rate affect future of SpO2? If I can understand, if we can quantitate, if we can quantify how the past of a time series, the past of a signal, affects the future of the other signal, then actually I can understand the causal relationship between these signals, and then I can use it for mapping the physiological system. So in this case, the concept of transfer entropy can be used. It is also easy to use it. It's an algorithm that can be used for mapping and for understanding the relationship between two or more component or physiological signals. And in this case, if you apply this idea and try to map the connectivity, you see very interesting result. This is the result from another student of my son. She has recently graduated from our university. So she tried to look at the map of connectivity and engagement of different components when we induce hypoxia in healthy individuals from FiO2 of 21%. If we reduce amount of oxygen, you see that we see more integration and we see more engagement, and we see that actually SpO2 plays an important role. SpO2 seems to be a hub of this complicated network. So basically, now it is possible by using this kind of method, by using and applying the concept of entropy, we can map, for instance, for each individual person, we can map the engagement of the cardiorespiratory system. This is an example of an individual, healthy individual during exercise. You can see which component plays an important role in engaging with other component. This is another example of a person who is hypoxic and is doing exercise during hypoxia. You can see that in this case, of course, SpO2 plays an important role here. And of course, you can see exchange of information. And you can, based on this possibility, it has potential for application. For instance, if we go back to sepsis and the idea of survival analysis with sepsis, if you look at a group of patients with sepsis in the intensive care unit, if you compare survivors and non-survivors, now if you try to map the engagement of system by including the SpO2 signal, as well as the heart rate signals, as well as respiratory rate signals, these signals can be easily measured in all clinical settings. Now, in survivors, you can see that the total amount of information is more than non-survivors. So that is actually very interesting. So you can, for each individual patient, you can map the connectivity, and it might have a potential application. This is probably my last slide, and I would like to say that now, if you map these networks and you measure total amount of information that is processed in this network, those patients who have very low total amount of information, the chance of survival is very low. People and patients with intermediate and middle intermediate amount of information processing, it is the survival is between this lowest value and and patients with high amount of total in transfer of information, you see very, very good survival. So it seems that there is potential for this kind of mapping of the network. And of course, it can be used for A&E admission in the emergency departments. It might be used as a signature for catastrophic illness in the intensive care unit. It might be used for in other contexts, of course, as well, sleep apnea and so on and so forth. I would like to thank you for inviting me to give this talk, and also my students and my colleagues and all of the collaborators at UCL and University of Portland, and also from Tehran University. I want to express my special thanks to Dr. Garib, who has been always very supportive to our research, and also he has always inspired me to try to understand clinical science within the context of physiology better. Thank you for your attention.
Thank you, dear Professor Mani. It was such an educational speech. You know, you spoke about the aspects of science that less physicians, less people think about. It was really educational, exciting for me. Dear Professor Garib is here with us, and he's going to say hello to you. Dear Professor Garib.
Thank you very much, dear Dr. Mani. Thanks a lot for your very informative, scientific, interdisciplinary lecture. You are a great scientist and also a great mentor, and also a very beloved friend to us. Thank you very much. And I had a question. So it seems that this SpO2 variability happens at the beginning of respiratory distress, for example, but if the body can maintain this chaotic situation, like heart rate variability, it shows that the body is controlling the situation and correlates with better survival. But it cannot be used as a fast measurement of the effects of the medication. For example, there are many indexes that we use for measuring the effect of the medication, but this can, first of all, is my question, this variability cannot be used as a measure of the effect of the medications that we are giving to the patient. And the variability is useful if the body can maintain it for sometimes, for example, for a few days. And this cause, like heart rate variability, seems to be favorable for the body. And how is the clinical, is it going to be used, or is it being used now for clinical decisions in intensive care units or in emergency departments in your university or modern hospitals?
Thank you, Dr. Garib. That's a very interesting question. So basically, I think I can answer the second part of the question. At the moment, this method is not used as a routine clinical practice in any hospital at the moment, because it is just beginning of this type of assessment, but it has potential application. If I go back to the first part of your question, so basically SpO2 variability, and especially entropy, tries to measure the amount of the engagement of the control system. So if the control system is under pressure, you expect to see more entropy. It does, and it is a healthy response. So what we guess based on the result from the patient with sepsis is that so there should be the increase in entropy relative to hypoxia is normal, but in patients who are non-survivors or have underlying disorder that cannot really maintain the homeostasis, probably the amount of increased entropy related to the degree of hypoxia is not adequate. So it is a way to measure the capacity of your patients, the capacity of homeostatic control in your patient.
The exhaustion of the system, yeah.
Exactly. Or of course, but we don't know if it is. It's a good question. We don't know if it is related to exhaustion or not. We have to study that. But we have used this technique in our hospital for instance, assessment of exacerbation in COPD. Of course, it is not relevant to pediatrics, So there is a potential, and it seems that it works, that you can predict the exacerbation in patient with COPD a couple of days before clinical diagnosis. So it might have this type of application, but how does it work with exhaustion and other type of course, physiological adaptation? We don't know yet. Hopefully, in future, I can talk more about its limitations and all of other applications later. At the moment, this is the area is in its infancy, and we have to see the result of future investigation and future trials.
Thank you very much. Thanks a lot.
You're welcome.
Again, so many thanks, dear Professor Mani, for joining us, for accepting our invitation. I hope we will be see you soon in person, and see you in our upcoming congresses as today. Thank you very much for joining us. Now we are going to continue our session by dear Dr. Vijay Srinivasan. درست دارم شیر میکنم. درست دارم شیر میکنم. میشه برام شیرش کنی؟ Sorry for the pause. Dr. Vijay Srinivasan is a pediatrician in Philadelphia, Pennsylvania, and is affiliated with Children's Hospital of Philadelphia. He received his medical degree from All India Institute of Medical Sciences and has been in practice for more than 20 years. He is attending physician at Pediatric Intensive Care Unit and Progressive Care Unit, Department of Anesthesiology and Critical Care Medicine. Dr. Vijay Srinivasan works in research and quality improvement programs dealing with critical illness, endocrinopathies, and nutrition to improve outcomes in critically ill children. His research focuses on stress hyperglycemia with tight glycemic control and nutrition therapy. We'll go to have a lecture on nutrition therapy in critically ill children. Let's listen to his knowledge.
Good evening. My name is Vijay Srinivasan, and I will be speaking about a topic dear to my heart: nutrition therapy in critically ill children, fact or fiction. I would like to thank the organizers of the 32nd International Congress of Pediatrics for their very generous invitation to me to talk about this topic. Before I get started, I'd like to share my disclosures. I'm employed by the University of Pennsylvania and Children's Hospital of Philadelphia. My work has been funded through research grants. I am a member of the American Society of Parenteral and Enteral Nutrition, as well as the Society for Critical Care Medicine, and the American Academy of Pediatrics section on critical care. I do not have any financial conflicts of interest. I work and live in the city of Philadelphia, which is on the eastern seaboard of the United States. This is a view of the city from the east facing west. In the lower left panel, you can see the Benjamin Franklin Bridge leading into the city, and you can see the skyline of Philadelphia. This photo is a view of the main entrance to the Children's Hospital of Philadelphia. This is one of the oldest institutions in the world and probably the oldest pediatric institution in the United States, being founded in 1855 and continues to grow. So why do we care about nutrition? Well, I'd like to highlight this famous quotation by Ronald Dahl. Broadly speaking, it might be argued that the most fundamental requirements for healthy growth and development in young children include loving support and protection by parents and caretakers, adequate nutrition, and adequate sleep. This becomes especially important in the context of critically ill children that we care for in the pediatric ICU. So the objectives of my talk today are to examine the evidence for timing of initiation of nutrition in critically ill children, and two, to evaluate the association of adequacy of energy and protein delivery with outcomes in critically ill children. This is the outpatient center for the Children's Hospital of Philadelphia. This was newly constructed and has been inaugurated and is a wonderful example of kid-friendly architecture. So, when we begin to break down the question of timing of nutrition initiation, it is important to look at enteral nutrition as well as parenteral nutrition. And these can be further subdivided into early initiation versus late initiation. What does that mean? And that is what we will get into now. So when should enteral nutrition be initiated? The recently published guidelines for nutrition therapy in critically ill children, released by the Society for Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition, highlighted that EN be initiated in all critically ill children unless contraindicated. Additionally, the guideline suggests early initiation of EN within the first 24 to 48 hours after admission to the PICU in eligible patients. So, let us now look at some of the evidence on the basis of which this guideline was proposed. So one of the largest studies that has been done in children on this topic was carried out in 2014, led by Teresa Mikhailov. This study enrolled 5,105 subjects from 12 PICUs. Retrospective data was collected for 6 quarters and in 8 PICUs up to 8 quarters, and the primary outcome was PICU mortality. Now, the analysis was adjusted with propensity scoring to account for the possibility that sicker kids are less likely to be fed enterally, which all of us know is very likely. In this study, the authors defined early enteral nutrition as enteral nutrition begun within 48 hours of admission to the PICU. The authors examined the effect of early enteral nutrition on mortality and observed that after adjusting for propensity score, the severity of illness, age, and center type, early enteral nutrition was associated with lower mortality for the entire population, as well as when they excluded malnourished patients and when they looked at mechanically ventilated patients, suggesting that the effect of early enteral nutrition was quite remarkable in this population. Additionally, they also observed a trend in mortality, and they noted that an increasing proportion of enteral nutrition relative to goal calories at 48 hours was associated with decreasing mortality trends. What about children requiring mechanical ventilation and/or vasopressor therapy? This is a population that is common to the pediatric ICU and is representative of probably the sickest children that we care for. In a study that our group recently did and published, we observed that early enteral nutrition was associated with improved clinical outcomes in critically ill children. This study enrolled 608 subjects from 35 pediatric ICUs and was a secondary analysis of RCTs that addressed the question of benefit of tight glycemic control with intensive insulin therapy. The study was notable for having prospective data collection of nutrition with a guideline that emphasized early enteral nutrition. The primary outcome for the study was 90-day mortality. An analysis consisted of logistic regression adjusted for age, body mass index, Z-score, inotropic support, severity of illness, primary reason for ICU admission, and PICU site. As you can see in this graph here, the top panel represents energy and the bottom panel represents protein. We defined early enteral nutrition as enteral nutrition begun within 48 hours of critical illness onset. And you can see that in both these panels, a good separation of energy delivery as well as protein delivery is achieved between the two groups of the early enteral nutrition and the no early enteral nutrition group. So what did we find? We observed that the early enteral nutrition group was associated with lower 90-day hospital mortality. Additionally, the early enteral nutrition group also had more ICU-free days more hospital-free days and more ventilator-free days compared to the no early enteral nutrition group. The early enteral nutrition group also had less organ dysfunction, as denoted by the Pediatric Logistic Organ Dysfunction Score, compared to the no early EN group. Collectively, the direction of all these findings suggests the benefit of early enteral nutrition in our critically ill children. Have there been any RCTs? There has been one RCT that has been conducted and published. This was from India, where they randomized critically ill children to either early or late enteral feeding. They enrolled 120 subjects from one PICU. This was an open label RCT, with 60 children being randomized within 24 hours of admission to early EN, and 60 children being enrolled in the late EN group after 24 hours of admission. The primary outcome here was PICU length of stay, and the secondary outcome was mortality. The authors performed a time to event analysis with Cox regression adjusted for severity of illness, malnutrition, and age. They did not find a difference in the primary outcome using the strategy of early enteral nutrition. However, they found a trend towards decreased mortality with early enteral nutrition initiation. Now, what about other unique populations of critically ill children in the pediatric ICU? Let us first examine children with acute respiratory failure. This study enrolled 106 subjects from one PICU, consisting of a retrospective cohort with acute respiratory failure, with the primary outcome being length of stay. The authors used logistic regression again to adjust for severity of respiratory failure, severity of illness, vasoactive agents, and age. In this study, early enteral nutrition was defined as EN initiation within 72 hours of PICU admission. When they looked at the overall cohort, they found that early enteral nutrition was associated with decreased PICU length of stay as well as decreased hospital length of stay, highlighting the benefit of early initiation of feeds. In another study from Singapore, the authors examined the impact of nutrition timing with outcomes in pediatric acute respiratory distress syndrome. This study enrolled 107 subjects from a single PICU, consisting of a retrospective cohort with ARDS that was followed for 7 days of illness, with the primary outcome being mortality. The authors performed a logistic regression to adjust for severity of ARDS, severity of illness, comorbidities, and adequacy of energy or protein delivery. In this study, early EN was defined as EN begun within 24 hours of onset of ARDS. The authors observed that a quarter of the patients received early enteral nutrition, and importantly, the early group was associated with decreased mortality compared to the late group. What about severe sepsis and septic shock, an all too common condition in our pediatric ICUs? The recently published Surviving Sepsis Campaign guidelines in children specifically highlights that there is a preference to commence early enteral nutrition within 48 hours of admission in children with septic shock or sepsis-associated organ dysfunction who have no contraindications to enteral nutrition. The evidence in sepsis is very limited, and the authors drew upon data from other studies as well as expert consensus to arrive at these guidelines. What about the population of children with traumatic brain injuries? In this study, the authors observed that initiation of nutrition before 72 hours is associated with better outcomes after severe traumatic brain injury. The authors enrolled 90 subjects from 15 pediatric ICUs as part of a secondary analysis of an RCT that addressed the question of therapeutic hypothermia in children with traumatic brain injury. There was no specified guideline for nutrition therapy, and the primary outcome here was mortality. The authors divided the subjects into 4 groups: no enteral nutrition within 48 hours, enteral nutrition between 48 to 72 hours, and enteral nutrition after 72 hours. They performed a mixed effects model to association of timing of EN with outcomes. And what they found was a dose response for enteral nutrition being started between the time of admission up to 72 hours, which was associated with decreased mortality and favorable outcome. However, the no EN group did very poorly, as can be seen in this table. In this study that looked at enteral nutrition initiation in children with traumatic brain injury admitted to the pediatric ICUs. The authors enrolled 416 subjects from 5 PICUs. This was a retrospective study with primary outcome being mortality. Again, the authors adjusted for age, severity of illness, PICU interventions, intracranial pressure, and Glasgow Coma score in this logistic regression analysis. The authors compared initiation of nutrition between patients with a Glasgow Coma Scale score of less than 9 versus those with a GCS score greater than or equal to 9, and observed that the group with a higher GCS score had earlier initiation of enteral feeds, with larger proportions of patients being fed enterally by 48 hours or 72 hours. When they compared outcomes associated with early and late initiation of enteral feeds, the authors noted a substantial decrease in ICU length of stay, hospital length of stay, as well as mortality when early initiation of feeds was achieved by 48 hours following admission. Lastly, I will highlight the evidence for nutrition initiation in children supported on ECMO, arguably the sickest group of children we care for in the pediatric ICU. This was a study that enrolled 51 subjects from one ICU and was a retrospective cohort that required extracorporeal life support. The primary outcome was mortality. The logistic regression analysis model adjusted for ECMO days, vasoactive agents, and renal dialysis to account for the possibility that this may have influenced feeding practices. The authors compared differences in nutritional practice and adequacy between survivors and non-survivors. Though there was no difference in the proportion of subjects that had EN initiated in the first 7 days across the groups, it is notable that in survivors, enteral nutrition was typically initiated within the first 48 hours, with a median of 36.8 hours. So with the information I've presented so far, I hope I've managed to convince you that early initiation of enteral nutrition is associated with better outcomes in critically ill children. This photo here is a view of the atrium inside the Children's Hospital of Philadelphia. So this brings us to the question of, what about parenteral nutrition? When should that be initiated? Again, we turn to the guidelines that were released in 2017 that specifically state that, based on a single RCT, initiation of parenteral nutrition within 24 hours of PICU admission is not recommended. However, we do not know enough information at this time, based on our current evidence, about the role for supplemental parenteral nutrition to reach a specific goal for energy delivery. Additionally, we also don't know the optimal timing to initiate parenteral nutrition to supplement insufficient enteral nutrition. The guidelines are therefore quite vague about that part. So the best evidence for the timing of parenteral nutrition to supplement insufficient enteral nutrition comes from this large randomized trial that was published in the New England Journal of Medicine in 2016. This trial recruited almost 1,500 subjects from 3 pediatric ICUs and was designed to be a randomized controlled trial of early parenteral nutrition to be initiated within 24 hours of ICU admission versus late parenteral nutrition to be initiated after 7 days of ICU admission. The primary outcomes were new infection and PICU dependency. The investigators performed a time-to-event analysis with Cox regression adjusted for age, severity of illness, risk of malnutrition, and diagnosis. This table compares the early parenteral nutrition group to the late parenteral nutrition group and observed that the early parenteral nutrition group had more new infections and a longer duration of stay in the pediatric ICU, resulting in worse outcomes compared to late parenteral nutrition supplementation. What was the reason for the observed clinical differences? The authors broke down the components of parenteral nutrition by macronutrients consisting of glucose, amino acids, and lipids, and interestingly observed that a greater exposure to amino acids in the early parenteral nutrition group was associated with worse outcomes and the likelihood of acquiring a new infection in the ICU, as depicted in this panel, compared to a strategy of late parenteral nutrition. This difference did not appear to exist as much for lipids, And in fact, for glucose, the opposite was true, where carbohydrates conferred some protection. So we know that initiation of parenteral nutrition within 24 hours is associated with worse outcomes. So now what about timing of initiation of parenteral nutrition? Is later better? At this time, the optimal timing of parenteral nutrition as a supplement to enteral nutrition remains unclear in children with severe malnutrition and high risk of nutritional deterioration. This graph here represents a schema to highlight the benefits and risks of using parenteral nutrition. The x-axis depicts time in days and the y-axis depicts energy. The top curve refers to total energy expenditure while the bottom curve refers to endogenous energy production. And you can see that a strategy of early enteral nutrition will allow calories and protein to be delivered in increasing stepwise fashion. Using parenteral nutrition in this early stage carries a considerable risk of overfeeding with parenteral nutrition. In contrast, once energy expenditure and endogenous energy production keep decreasing over time, and if enteral nutrition is inadequate, that appears to be the right time to start using supplemental parenteral nutrition to reach total energy expenditure needs. At this stage, there is a high risk of underfeeding without the use of parenteral nutrition. So we have now examined the timing of initiation of nutrition, both from an enteral route as well as a parenteral route. This photo is a view of the Children's Hospital of Philadelphia from the main building at nighttime. So moving on to our second objective of assessing the adequacy of energy and protein delivery, the guidelines published in 2017 again emphasize that on the basis of observational studies, it is reasonable to consider achieving at least 2/3 of the prescribed daily energy requirements by the end of the first week in the pediatric ICU. However, as you can see, the quality of evidence is quite low with a weak grade recommendation. In terms of protein, on the basis of evidence from randomized controlled trials, the guidelines recommend a minimum protein intake of 1.5 grams per kilo per day, and possibly needing even higher than this threshold. The quality of evidence for this is moderate, and the grade recommendation is strong based on the evidence. We will now examine some of the studies on the basis of which these guidelines have been developed. One of the landmark trials published in 2012 by Dr. Mehta and colleagues enrolled 500 subjects from 31 pediatric ICUs. This was a prospective cohort with nutrition data collection for 10 days, with the primary outcome being mortality at 60 days. The investigators performed a logistic regression adjusted for severity of illness and body mass index Z-scores to study their outcomes. The investigators examined the relationship between energy adequacy and 60-day hospital mortality and broke down the energy delivered into tertiles, as you can see in this table. They observed that when energy was delivered in excess of the highest tertile, which was more than 66.7%, hospital mortality at 60 days was considerably lower after adjusting for confounders. They concluded that intake of a higher percentage of prescribed dietary energy goal via enteral route was associated with improved 60-day survival. However, notably, nutrition delivery is generally inadequate in mechanically ventilated children across the world in this landmark trial. The study of nutrition delivery in children with pediatric acute respiratory distress syndrome also examined the adequacy of energy delivery. Briefly, the study consisted of 107 subjects from one pediatric ICU and was a retrospective cohort with ARDS followed by 7 days of illness. The primary outcome was mortality. The authors had performed a logistic regression to adjust for severity of ARDS as well as illness, comorbidities, and adequacy of energy or protein delivery. What they observed was survivors tended to receive a higher median percentage of calories, as can be seen in this figure with the solid lines. However, non-survivors received a much lower median percentage of calories, as can be seen through the dashed lines. Energy delivery was also examined in the study of nutritional practices in children supported on extracorporeal membrane oxygenation. This study enrolled 51 subjects from one pediatric ICU, consisting of a retrospective cohort requiring extracorporeal life support with the primary outcome of mortality. The authors used logistic regression adjusted for ECMO days, vasoactive agents, and renal dialysis. Based on the multiple logistic regression analysis of factors affecting hospital mortality, the investigators observed that adequacy of enteral nutrition was an independent risk factor for hospital mortality, and observed that the greater the EN delivery, the lower the mortality, after adjusting for confounding variables. This is another view of the Children's Hospital of Philadelphia, of the Research Institute and the Rehabilitation Center. The tall building on the left is the Research Institute, and the sandstone building on the right that says Children's Seashore House is the Rehabilitation Institute. Finally, we examine the evidence for protein delivery. This study, performed by Dr. Mehta and colleagues, observed that adequate enteral protein intake was inversely associated with 60-day mortality. They enrolled 1,245 subjects from 51 pediatric ICUs, consisting of a prospective cohort with nutrition data collection for 10 days. The primary outcome was 60-day mortality. The investigators performed multivariable logistic regression with generalized estimating equations to model the effects of PICU characteristics, patient characteristics, and nutrient intake adequacy. And what they observed was that the probability of mortality decreased as protein delivery was increased, as can be seen on this panel. This study by Dr. Janhao Lee and colleagues from Singapore also looked at protein delivery in children with pediatric acute respiratory distress syndrome. Again, to refresh your memory, this looked at the primary outcome of mortality, and the authors performed logistic regression to adjust for severity of ARDS and illness, as well as comorbidities and adequacy of energy or protein delivery. And again, the authors found that survivors, represented by the blue solid line, tended to receive a higher median total protein per kilogram as compared to non-survivors, represented by the dashed line, that received less protein per kilogram. So with this, I hope I've convinced you that there is a need to provide adequate energy and adequate protein to improve outcomes in critically ill children. This sketch is rendered by an artist and represents the front facade of the Children's Hospital of Philadelphia. The building on the left contains the ICU units on the 2nd floor, 6th floor, and 7th floor. The main building in the center and the right contains all the inpatient units. So my take-home pearls are: enteral nutrition within 24 to 48 hours of PICU admission is associated with better clinical outcomes. Parenteral nutrition within 24 hours of PICU admission is associated with worse clinical outcomes, but the optimal timing for parenteral nutrition is unknown and may need to be individualized. Energy or calorie delivery of at least 2/3 of prescribed needs by 7 days of PICU admission is associated with better clinical outcomes. And a daily minimum protein intake of greater than 1.5 grams per kilo per day during PICU admission is associated with better clinical outcomes. I'd like to thank you for your time and attention.
Thank you for staying with us. Unfortunately, we didn't have Dr. Srinivasan here with us due to time differences between us and him. And I hope we will be able to have him live in our further congresses. And now we will have the next lecture by dear Azadeh Assadi on decision making in ICU. Azadeh is a pediatric nurse practitioner at the cardiac critical care unit at the hospital for sick kids in Toronto, where she provides medical care for critically ill children with congenital and acquired heart disease. She is also a PhD candidate in biomedical engineering at University of Toronto, having earned her Master of Nursing in 2016 from the same university. She also holds 2 bachelor's degrees, one in science and one in nursing. Her PhD focuses on understanding the differences in cognitive process in clinicians and applying these differences in the design of clinical decision support system. Outside of her doctoral thesis, Azadeh is also studying the effects of AI model in clinician behavior and has developed a human factors framework to safety and effectively deploy and integrate models in the clinical space. And again, unfortunately, we don't have her live today with us. So she sent us a backup video and we will go to here and watch.
با سلام، میخوام اول از همه از دستاندرکاران این کنفرانس نهایت تشکر کنم از اینکه منو دعوت کردن. باعث افتخار منه که امروز اینجا باشم. من آزاده اسدی هستم و در بیمارستان کودکان سیکیدز تورنتو در کانادا در بخش ICU قلب جزء تیم پزشکی در نقش نرس پرکتیشنر کار میکنم. و همچنین الان در حال کامل کردن دکترام هستم در زمینه بایومدیکال انجینیرینگ در دانشگاه تورنتو و موضوع پژوهشم در مورد طراحی دیسیژن ساپورت سیستم هایی هست که بر حسب طرز فکر پزشکان طراحی میشن که راجع به این موضوع بیشتر براتون توضیح خواهم داد. علاوه بر این سوژه پژوهشی دیگرم راجع به تاثیر هوش مصنوعی در تصمیم گیری پزشکی هست و به همچنین راجع به این که چطور میشه این مدل های هوشمند رو طوری طراحی کنیم که تاثیرشون روی تصمیم گیری هامون قابل پیش بینی باشن و اینکه بشه به راحتی اونها رو جزئی از تکنولوژی مورد مصرف همیشگیمون قرار بدیم. من اینجا ازتون عذرخواهی میکنم ولی من راجع به مسائل پژوهشیم هیچ وقت به فارسی صحبت نکردم و از اونجایی که وقتمون محدود هست باقی این صحبت رو به انگلیسی خواهم انجام داد، ولی اگر سوالی چیزی باشه حتما چه به انگلیسی چه به فارسی حتما در خدمتتون خواهم بود. So the topic of our discussion for today is about incorporating clinicians' cognition in healthcare design. And as it relates to this topic, I have no conflicts of interest to disclose. For the course of this presentation, I'd like to first start off by going over what is human factors engineering and give some examples of what some of the consequences of poorly designed technology can be. And ultimately, I'll take a deeper dive into applying an understanding of clinician cognition in system design. So human factors engineering is the application of knowledge about human capabilities and limitations to the design of tools, devices, systems, environments, and organizations. The picture you're seeing here is that of an EpiPen, which is used to administer epinephrine in cases of anaphylactic shock. This tool is designed so that the blue cap is removed and the orange end of this pen is where the needle comes out to deliver epinephrine. However, given that this is called an EpiPen and people correlate it to or associate it with an actual pen, in an actual pen, when you take the cap off, the business end is underneath the cap. And so many people assume that it's actually the blue end of this device that's delivering the medication. And so they put their thumb on the orange side, and when they go to press this against the thigh, which is what's recommended, they end up delivering epinephrine to their own hand. And so it's an incorrect use of the device. Another example, more common from the healthcare field, is the vials of medication that we often have that have similar colors or prints and shapes, that makes it hard to distinguish one from another. So what you're seeing here is 2 vials of heparin with 2 different concentrations. One is 10 units per mil and the other is 10,000 per mil. And yet both of them have a blue shaded label and a greenish shaded cap. And it's not hard to imagine that if someone is tired or has a lot of cognitive load, it's very easy for them to reach for the wrong vial and not notice the difference in concentration, leading to some degree of error and harm. And from a safety perspective, this lack of human factors consideration is a particular problem in the pediatric world, since much of the things that we use are actually not designed for pediatric care in the first place. An example is phenylephrine, which is made in vials of 10 milligram per mil concentrations. And given that the pediatric dose range for this drug is somewhere between 0.5 and 1 or 2 micrograms per kilo per dose, and the average weight of a neonate is somewhere between 3 and 4 kilos, that makes roughly for a dose range of about 2 to 8 micrograms if we're intending on delivering this medication as a bolus, which is often used for that reason. And so it's very difficult to draw up this very small dose from the vial directly, particularly under conditions where there is an emergency and there's a high cognitive load associated to it. The workaround that our anesthesia department has used around this is that they often dilute the drug in a 200 milliliter bag of saline, and that way they drop the concentration to something like 50 micrograms per mil, which still doesn't make for easy math, but at least it decreases the concentration and it makes the effect of an error in volume that's drawn up and administered a little less severe, although that is highly relevant to the size and weight of the patient that's being delivered to. This is another example. This is becoming more and more common. This is lack of human factors consideration in design of electronic health records. And given that we're moving more and more towards an electronic health environment, this is becoming more common. And if you were to take a minute to look at this particular screenshot, which is meant to capture the lab results of a patient in a particularly popular electronic health record system, what sorts of things strike out? When we reviewed this particular screenshot, there were a few things that we noticed. For one, everything or nearly everything in the screen is yellow, and it's very hard to know why that is the case. Similarly, all the values within the field are also bolded and italicized, and again, it's hard to know quickly why that is the case. And because the entire background is yellow, it's very hard to distinguish the exact features of these red arrows that are meant to show out of range values. And this is particularly a problem if this is being viewed on a low resolution screen, so different to the screen that I'm showing. There's only 5 sort of categories of time that are shown here, and it's not clear as to why that is the case. It's very hard to appreciate a trend that goes prior to 2300 on this timestamp without scrolling or going back and forth a bunch. And it's also hard to appreciate why this particular order of labs was selected, so why is CBC shown first, then arterial blood gas results, which one would argue in an ICU setting are probably more important and of critical value, shown further below. They're also not very easily distinguished from each other. And if you add all of these together, for someone who is on call in the middle of the night with many patients of high acuity, this presents an undue burden on their cognitive load as is, and it makes it very hard for them to be able to find the values that they need, and also makes it easier for them to make errors and to miss things, creating opportunities for error and harm. Now, If we include some human factor considerations in this screenshot or in this page and redesign it a little bit, you can get something like this that is a little bit more clearer. Some of the abnormal values are much more easily identified, and you can see that we've changed the order in which we're presenting these values to make a little bit more sense from the way the clinicians tend to approach these lab values, looking at the more important things first. Now you could ask, so what if it looks a bit nicer? Does it actually work or make a difference? And so to test that, we actually took our proposed modified screenshot and we tested it with our clinical fellows and trainees who had been on call for 22 hours or so. We tested it in a normal patient room with all the normal background noise and interruptions. We also scheduled in some distractions that would be reasonable that they would normally get to make the experience very realistic, and we asked them to complete a series of tasks similar to what they would do as they prepare for morning handover. We looked at two things, broadly speaking. From a quantitative perspective, we looked at how much time it took for them to finish the tasks, as well as how many clicks it took for them to complete a task and how often they had to scroll. And qualitatively, we sought their feedback and obtained some usability scores. And the results that you see on the right are what we found. So with the new design, we could decrease the number of clicks by about 50%, and the number of scrolling by about 30% as they completed a task. And the total time to completion was about 20 seconds less on average. And of course, qualitatively, everybody described the new design to be superior and better to the existing setup. So now I want to pivot to the topic of designing decision support tools with consideration to clinician cognition. We looked at a few simple examples from the EHR system as well as the medication vials, but now we want to look at it from a higher degree of cognitive processing and see how we can utilize an understanding of that in system design. Specifically, I want to talk about utilizing an understanding of the differences in thought processes of experts and non-experts to improve patient care. And for this example, I'm going to go through a series of studies from my dissertation, which focuses on ultimately improving the acute care we provide children with known congenital heart disease. We chose this particular population because we know that this population is very fragile and that they have many more hospital admissions and they experience a greater degree of mortality, both in the emerge and in their hospital stay overall. What's more is that the admitting diagnosis for these patients is often acute respiratory disease or gastrointestinal issues, and as we saw before, nearly 50% of these patients get admitted to hospital. And the challenge here is that many of these children experience heart failure as a result of one of these common GI or respiratory childhood illnesses. And it can be difficult for ED physicians to identify whether a patient has just a simple gastrointestinal or respiratory illness, or that there is also the addition of heart failure that is exacerbated because of this intercurrent illness, particularly given that the symptom presentation for either of these cases can be very similar. It's therefore not surprising that a study of all ED physicians in the state of Michigan, as conducted by Cashin and colleagues, showed that 74% of these ED physicians were at least somewhat uncomfortable caring for some of these patients in their emergency department. Now, some of that could be due to insufficient training in congenital heart disease, given that this particular training is an elective rotation for these ED physicians, and it can be around 2 to 4 months, compared to CHD experts who receive at minimum 3 to 4 years of training in CHD. In this light, as I mentioned earlier, we wanted to find a way to improve the care of these patients and help these ED physicians using a socio-technological approach that wouldn't strictly involve suggesting more training in the field. So to do that, we set out to compare the macrocognitive functions and processes of CHD experts and ED physicians using the critical decision method. Macrocognition is a technique used to study the cognitive work of those who make decisions under complex settings and constraints, particularly time constraints. The high acuity environment of the emergency department and the pediatric critical care unit, as well as the uncertainty and risk involved with the decision-making surrounding the management of these patients, warranted the use of this particular technique. We reached out to a major academic pediatric hospital where they had a cardiac intensive care unit that looked after some 800 pediatric patients with heart disease every year. And it was staffed by CHD experts who were trained in both cardiology, pediatric cardiology, and pediatric critical care. The emergency department in this hospital also saw around 50,000 pediatric patient visits every year, and of them, about 6,000 of them would get admitted annually. This department was staffed by 26 pediatric emergency medicine physicians. The participants that we recruited from this institution then for our CHD experts group were obviously physicians from the pediatric cardiac intensive care unit, and we interviewed 2/3 of them. And for the ED physicians, we looked at recruiting physicians who worked in the high acuity emergency department and that they had cared for, had experience having looked at pediatric patients with congenital heart disease. And so of the 26, about 12 of them met our inclusion criteria, and we interviewed 58% of them. For the actual study, we conducted semi-structured audio-recorded virtual interviews, and we asked our participants to recall a scenario from their experience in caring for an acutely ill pediatric patient with congenital heart disease. And we asked specific questions around understanding their decision-making and their thought process, trying to get at what they understood of the patient and how and why they came to make the decisions they made surrounding their care. We took those recordings, transcribed them, and then completed a thematic analysis based on previous work that was done by Klein and Schubert in the field to try and get an understanding of what these thought processes and cognitive functions were in this group. So what did we find? Quantitatively, we found that both experts and ED physicians spent the majority of their time on sense-making and anticipation. So trying to understand what's going on with a patient and why, as well as trying to plan a course of treatment, safety measures to put in place, and the kinds of things to look out for. That's not surprising. We also found that a considerable amount of time was spent in managing clinical complexity, so gathering various data to try and achieve an understanding of the patient. And for emerge physicians in particular, they spent a fair bit more time gathering a broader set of data. And they also spent some time consulting the CHD experts to not only understand what to do with their next steps, but also to determine where to relocate the patient to after the emerge visit. Our qualitative analysis was a bit more interesting and more revealing. We found that when establishing an overall understanding of patients, CHD experts were able to quickly narrow in on cardiac issues and symptoms, while emerge physicians tended to keep a broad take on possible differentials. When looking at the differences in their sense-making, we found that CHD experts recalled lots of detail about the patient's heart, such as various intracardiac pressures and gradient, and they focused on why the patient was presenting as they were, focusing on the current presenting physiology and using it as their decision-making guide. ED physicians, on the other hand, recalled broad categories, such as describing a patient presenting with a shunt-dependent lesion, and they focused on understanding what was going on with the patient as opposed to the why. And they often focused on evaluating the patient's state and risk based on their deviation from baseline targets. For anticipation, CHD experts focused on the expected trajectory to avert problems, while ED physicians focused on ruling out issues to reach a diagnosis. We drilled down further into the differences in sense-making between our CHD experts and ED physicians because what you understand about the patient ultimately derives much of your decision-making. Sense-making is the process of understanding a given state, as I mentioned before, and it's often viewed in two categories, retrospective and prospective. Retrospective sense-making is understanding what is going on given the data that is available to you at that point in time and your own frames or predefined cognitive maps regarding a particular scenario. A straightforward example here is when you see someone walk in with a bloody hand and you know that they have likely in some way cut or injured their hand, and so they need to have that wound cleaned and dressed. Prospective sense-making is being able to understand what could unfold given the current data and related cognitive frames. That may not exactly fit the current situation, but you can extrapolate from it. So this is how a surgical assistant, for example, knows what surgical instrument to hand to the surgeon without the surgeon asking for it. So during retrospective sense-making, we found that our CHD experts were able to describe the patient's current physiological state based on their presenting symptoms and the described anatomy. So for example, they would say that a patient is experiencing restrictive right ventricular physiology. Emerge physicians, on the other hand, could suspect heart failure, but couldn't specify the physiological state that the patient was experiencing. During prospective sense-making, we found that CHD experts would use their expected physiological state for the patient based on their native cardiac anatomy to anticipate the patient's course of deterioration and suggest interventions to prevent it. So for example, they would say that they were starting CPAP to reduce the afterload to the left ventricle and decrease the degree of left AV valve regurgitation to ease the symptoms of left atrial hypertension. ED physicians, on the other hand, had a greater difficulty describing the next steps based on physiology and focused instead on treating symptoms. So they would say that the patient is having an increase in their work or breathing and that the patient could benefit from the use of CPAP to support them. Finally, when looking at the task diagrams of these clinicians, we found that CHD experts would evaluate a patient and establish an understanding of their clinical presentation and state. And based on that, imagine an ideal physiological state for the patient to be in. And every decision with respect to how they would treat the patient would be around achieving this transition from a current state to an ideal imagined physiological state for the patient. On occasion, they would have to deviate and try to stabilize the patient on first pass before achieving an ideal state, but the decisions they would make in order to achieve clinical stability was also driven by what would be needed to achieve an ideal state. This was different to emerge physicians whose primary goal after understanding a patient's presentation was to achieve clinical stability. And oftentimes, they either didn't have an understanding of what the ideal physiological state should be for this particular patient or how you would get to it, as well as not necessarily appreciating that some of the interventions that would bring a patient to clinical stability may not necessarily bring them to the ideal physiological state as well. So, now that we understood the differences between these two groups of clinicians, we set out to find a way to supplement the gaps that the ED physicians had in their macrocognition when it came to treating this particular patient population. We chose a technological solution because from our previous studies, we knew that education alone wasn't going to be well received or sufficient. And we wanted to make sure that we didn't change the way ED physicians thought altogether either. After all, their existing macrocognitive processes was perfectly fine for their role overall and for the collection of diseases they would normally see in the emerge. On top of that, introducing completely new frames and causing a frame shift could actually lead to greater errors, as the CHD frame would generally be ill-suited for every other patient that is cared for by an ED physician. Not to mention that this could potentially lead to premature closure of diagnosis, for example, and lead to missing alternative diagnoses that would explain a patient's presentation that's not heart disease related specifically. Some of the possible solutions in this regard could include making it easier to navigate through the electronic health record system, for example, or increase the availability of CHD experts to ED physicians. And we could also use a decision support tool that could at least temporarily bridge the gap that exists until further expertise is sought by ED physicians. To design such a system, we used a decision-centered design approach. In our interviews, we had identified the key decisions that ED physicians and CHD experts had to make in managing these patients acutely, and then looked at what types of data they each used to understand the physiology and make these decisions. We also looked at how they synthesized data to come to an understanding of physiology, and also accounted for the kinds of data that CHD experts already knew and ED physicians had to look for in patient chart. An example there is that CHD experts always knew what types of saturations they could expect of a patient with a particular heart disease, whereas ED physicians would have to look for this data in the patient chart. We also identified gaps in cognition of ED physicians that hindered their ability to make sense of the presenting physiology, and we made sure to address those gaps as well. An example there is that we found out that ED physicians had a harder time visualizing the specific cardiac anatomy for a patient based on what was described to them by parents or what was written in the chart, and we made sure that we were able to capture that in our decision support tool. And so to be able to put it together and help with the flow of this tool, we looked at the order in which ED physicians communicated with each other when handing over a patient, and we utilized that sort of flow in designing how we would put together the various pieces of this decision support tool. We then set out to evaluate its effect and its impact. So at first pass, we completed a usability study similar to what I had showed you before with the electronic health record system. We identified some issues that we addressed and made changes. And then we also set out to evaluate the effect of the tool on decision making for these ED physicians. And to do that, we set out to conduct a scenario-based simulation study that was counterbalanced. We recruited clinicians and we gave them each 2 scenarios of equal complexity, and we asked them to treat each patient. For one case scenario, clinicians had access to the decision support tool, and for the other one, they did not. And we basically looked at the changes in their cognitive processes in the presence and in the absence of the tool. So, what did we find? Well, we found that clinicians using the app took approximately 40% more cardiac-specific features into consideration when managing these patients compared to when they weren't using the app. We also saw that a symptomatic approach alone was pursued less when physicians had the app compared to when they didn't. And so what this means is that potentially using the app has helped clinicians be more considerate of the patient's cardiac state, but not completely forego the management of the intercurrent illness, which likely destabilized this patient in the first place as well. If we break down some of the features from the previous graph into its components, you can see that the clinicians had a greater understanding of what the expected physiological ranges of these patients should be, what diagnostic tests to pursue to better understand the cardiac nature of their presentation, and what therapy they should pursue that is supportive of their unique congenital heart defect when they had the tool available to them compared to when they didn't. But one last thing I want to point out is that despite the tool, you can see that we weren't able to get the ED physicians to come to the correct physiology-based diagnosis for the patient. One reason for this can be that clinicians perhaps need to use the tool more often and become more familiar with the physiology and the patient to be able to come to this correct diagnosis. So this basically refers to the teaching effect that the tool can have on these clinicians. Another reason, though, can be that maybe we should be more explicit in the content of our decision support tool and maybe provide a list of possible differentials for clinicians to ponder upon. And so those would be some of the things that we would look at in our future iterations of the app. And so in closing, I want to draw attention and emphasize the fact that as part of our roles as clinicians, we are constantly engaging with risk. There is in fact a neat conference that's held annually called Risky Business, and it actually evaluates the effect of risk in healthcare and in clinical practices overall. The reason for that is very complex, and there are multiple features to it. A few of them can be, for instance, this near infinite number of variables that we consider in our decision making, and there is quite an assortment and permutations that we could consider these things in our decision making. There is near absence of certainty in how many aspects of medicine actually function. Some of the simple examples are that we don't actually know for sure how a patient would respond to a particular therapy or how they would respond to a particular illness that is the same illness experienced by someone else. In hospital settings, there are multiple players with changing roles and shifts, and they have a variety of experience and expertise, and it's hard to get the exact same result and outcome time and time again. Not to mention external stressors like how many hours someone has slept the day before, what are some of the environmental stressors on their cognitive processing, and everything else that would further add to the complexity of our decision making, the cognitive load that we each experience, and then the risk that's associated to how we think. What's more is that an undue burden on clinicians' already loaded cognition can further precipitate a degree of risk that could eventually lead to patient harm. And one way that I hope I have conveyed to you during this talk is that we could potentially use cognitive-based designs to not only help decrease the overall risk, but also improve efficiency and contribute to better decision-making overall. And so with that, I want to thank you for your time and for having me in this conference. And if there are any questions, I'm more than happy to answer them as they come anytime. Thank you.
Thank you very much, dear participants, dear friends and colleagues, for staying with us. We're going to finish our exciting Congress tonight. It was such a great honor for me to be here with you. And thank you for all dear professors for accepting our invitation. Their acceptance made our Congress really unique. I hope we would have more projects like this in the future, and thank you for joining us these 5 nights. Dear Iranian participants, do not forget to take the exam at the end of this session in order to receive your CME credit via ircme.ir, and do not forget to register on our web application in order to receive your certificate of attendance. Thank you very much. Good evening, good night, and good morning. See you soon. Thank you, dear Professor Mani. Thanks for joining us. Good night.